Now, I want to show you how to manually measure a round or elliptical object. And if you go up here, there is what's called the distance pair, or Control D. So if you click that, then you click here, you drag it, and voila, it measures it for you. That's pretty cool. So we'll go straight up. So we want to do the mid-sinus diameters, right? So you go up and say, hey, this is about the mid-sinus right here. The way we measure the aortic root for TAVR is sinus to commissure. And right here, you can see this is the intraatrial septum. And so what you'll do is, or what I'll do is I'll find the commissure. If I want to, here's the left coronary artery, the left sinus here, right sinus, non-coronary. Intraatrial septum is a good marker for the non-coronary sinus. You can click on the commissure, drag to the edge of the sinus. So that left sinus is 30.9 millimeters. I click up here, I'll do the right sinus, and that's 28 millimeters. And then I'll click, and the non-coronary is 31. Okay? Everybody good with how we measure sinus to commissure? If we go up, so if you look, here's the height of the sinus right here. If you want to measure the height of, say, the right coronary sinus, this is how you might do it. If you want to measure the height, the other height that you might want to measure is the height of the coronary arteries. So if you want to make those measurements manually, here's the right coronary artery, here's the annular plane. You would click on your D tool, you find this edge of the ostia, and you measure the perpendicular up from the plane. You can see the right coronary is 14 millimeters. I'll then rotate this around, and I'll find the left coronary ostia. It comes off kind of funny on this case, but so you do D, and if you were putting TAVR, this left coronary is lower. It's 9.8 millimeters. The other measurement that you'll want to make is the sinotubular junction. So you come up here to the sinotubular junction, and then just measure the diameter. You could do Control D, which will do the distance pair. And then the ascending aorta, you come up and measure the diameter of the ascending aorta. Hold on a second. Let me just say what you said. So the reason why the STJ is important is because you're going to be putting this introducer in, depending upon whether it's a balloon expandable, whether it's self-expanding. There are different constraints related to how bendable those deployment devices are, and you can end up with kind of too much stuff or different angles in there. And so you want to give your interventionalist the size of the STJ, the size of the mid-sinuses, both for the device and for the deployment apparatus, so that they know with the tools that they're going to use that they have enough space to do all that. So that's why we do a series of measurements. Each device probably has some device-specific measurements, but as was alluded to by Joe, for TAVR, we've kind of come to kind of a consensus on what those measurements are, and pretty much all the manufacturers use those measurements. The one thing that I would say, Dia, and you can chime in too, and we'll go on to the next one. I want to mention two things, the ascending aorta, and we'll talk about the annulus. And you may have mentioned the annulus. There's two measurements. One, we have a diameter by area and a diameter by perimeter. Why is that? We have the diameter for area for the balloon expandable devices that were FDA approved based on the area of the annulus. The perimeter was for the self-expanding, which were done based on the circumference. And so I use those two devices. If you measure the perimeter and you measure the area, those should be pretty close together. If you have a perimeter diameter and an area diameter that's, I would say, more than a millimeter. Well, I like to have them about a millimeter or less off, but I look at those as a quality measure and try to understand why those are off. If they're off, there's generally something odd going on with either the shape of the annulus, the way it was measured, motion artifact, a chunk of calcium, something's going on to make the perimeter and area be off by more than 2 millimeters or something like that. They should generally be within a millimeter, millimeter and a half or less. Sometimes they're right on, but they should be very close. So we talked about the mid-sinus and sinotubular, which is related to the device and deployment of the device. And we talked about that's important because you don't want to obstruct the coronary sinuses. You don't want to rupture the aortic root, big complications. The ascending aorta, why do we measure the ascending aorta? Anybody know why we measure it? Well, if you like surgeons, which I like surgeons, I like my cardiac surgeons like me, and one of the reasons why they like me is because I measure the ascending aorta. So if you're an interventional cardiologist, you don't want anybody to measure the ascending aorta. If you're a device manufacturer, don't measure the ascending aorta. But if you're a patient and you have a big ascending aorta, you really don't want your first valve to be a TAVR valve, right? Because if you're a young patient and you've got a 48 millimeter aorta or 47 millimeter aorta, that's probably, you have an aortopathy that's probably going to be repaired in your lifetime, okay? And so some constructive discussion needs to be had about that and their aortic valve disease, because if they're going to go in and replace their ascending aorta, they can go in and put a bioprosthetic surgical valve with a big annulus. And that valve, if the patient lives for 10 to 15 years, is going to wear out. And it's much easier to do a valve-in-valve in a SAVR or surgical valve than in a TAVR valve. And if they live for another 15 years and they have to have a valve, and a valve, it's going to be way better off than having 3 TAVR valves in their aortic root. So measure the ascending aorta. Now, the original protocol for where you measure the ascending aorta, I think, is like 5 millimeters. It's some ridiculously short distance. And it underestimates the dilatation of the ascending aorta. So I will almost always measure the ascending aorta where it's largest, which is generally by the right pulmonary artery, okay? So the valve companies will measure it very close to the sinotubular junction. And a lot of people with aortopathy, that will be just flaring out, so it will be borderline. But be sure to do an extra measurement where the aorta is actually largest, even if it's on your CTA image.